All right, good morning, gentlemen. My name is Josh Constantino. I'm your EMS liaison at Medical Center of Louisville. I've been there for roughly 8 years, and I've started out as a paramedic. I was a tech there in the ER, and then I got my nursing degree. So I'm a nurse and a paramedic, and now I'm your EMS liaison. So you may have seen me there in the department. I've been charge nurse, floor nurse, all that kind of stuff, and so this is my new gig for you guys. We've got a couple other people with us from Medical Center Louisville as well. We've got Jennifer Turner, she's our trauma coordinator. Next to her is Patricia Brown, she's our stroke coordinator. Next to her is Courtney, she is our sepsis coordinator. And then we've got Van here, and he's in charge of our cath lab as well. We're going to go over a couple of good success stories for you, give you some feedback on what you're doing in the field, give you an idea of kind of closing that loop as far as all the patient care that you guys are doing to really show that you are making a difference. My presentation isn't as cool as that. Mine's all about construction and the flow of traffic and what we're going to see here for the next year. Okay, so a lot of this is going to be communication between you guys and myself and what's working and what isn't working. So let's go ahead and just jump right on into it. All right. So if you were to look out of our ambulance bay doors here and you're looking south, we've got 35 just over here, and we've got, this is our helipad just over here on the east side of it, and this is Elm Street that you see right here. Now this is where the construction base is actually set up. Now if you've been to the hospital here since roughly Wednesday is when they started kind of moving in, and you're going to see something like that now. Okay. In fact, just this morning when I drove by, they have fences all around it. This is that same exact view. We've got our helipad over here. This is 35 that you have, and this is Elm Street right here. So they're just going to be setting up base there. All of their large equipment's going to be posted up over there. Some prefabricated items for the new ER going over there, and it's just going to be their big staging area. We've made sure to keep it plenty far enough away from the helipad to where we're not going to have any issues if you have to fly someone in, fly someone out, anything like that whatsoever. Okay, so starting today actually is when we're going to be looking at tearing up this lovely, beautiful area. So as you view our emergency room, and this is where you guys would normally be pulling in, keeping traffic flow heading out this way, all of these shrubs, these bushes, all of this entire median area is going to start getting torn out because our new ER is going to start construction just onto this side and then heading back out towards 35. So with that being said, we're going to have to close Elm Street down. When we close all of Elm Street down, you guys have to have a way in and out, so we've got to get started on this. So they're going to start pouring, getting all these out, and then they're going to do breaking up the curb on either side. This shouldn't affect traffic flow for you guys while they're doing this week at all. What we're going to be doing is making a big loop around into this area here, and you're going to have aggregate and concrete down here. So you'll be actually pulling in backwards off of Elm. You'll be pulling in here and then doing a loop through between the two pylons. We've measured that out with a couple of ambulances. There'll be no problem with getting turned around in there, but it is a little bit snug. The other thing that we're looking at as well is that that's going to put the exhaust on the other side to where it may be having a chance to go into the emergency room. So as we start dealing with some of these different issues that are popping up, make sure to go ahead and just communicate with me, hey, we're just blowing too much exhaust in there, or it doesn't really seem to be an issue type of thing, because as we move forward with it, we got to be really cautious of this one-way traffic. So here's a big overhead view of everything that we're doing here. So this is actually going to be the new emergency room. Projected completion is October of 2015. Okay, so we're going to have a unique traffic flow until that point. The little green box that's included into here, that is going to be an extension of the awning. We're essentially doubling the awning size at what we have right now in order to have 4 ambulances in the bay. Once that's completed, that could all be covered up for dropping patients off. So what we've got here is your usual flow of traffic is not really going to change too terribly much, because as you guys come from the west over here, you're going to take Main Street down to Edna. Edna is going to run same parallel with 35, and then you're going to take Elm in. Now what you're doing right now is as you're going down Elm Street, you're going past the ER and then you're doubling back, right? So what you're going to be doing is, instead of, because Elm is all going to be completely closed off of here, so as you come down Elm Street, you're actually going to be pulling directly in and dropping patients off. So it'll be kind of backwards of what you guys are used to right now. As you drop that patient off, all of this yellow area we are going to devote just to you guys, to where you're going to be able to pull through the rest of the way, stage the ambulance over here. If you have to do any further cleaning, finish report writing, finish stocking, anything that you guys would happen to have, we're going to have all of that available for you as well. So as we look at this overhead, this is Elm Street. The construction company is going to block it off over here. This is Deegan. It's like a little alleyway. Not a lot of traffic goes down that. And then also Ray Dunning, that's the main entrance into the hospital here. It will be open, but as you can see, the footprint of the new ER is going to block it off just to the south of the primary main entrance. So you won't have access to the ER down that road. It'll all have to flow down Main Street to Edna into Elm. Now, if for some reason you're coming from the south, we have Purnell Street here as well. You could take Purnell over to Edna up into Elm as well. Now the tricky part here is, guys, is that right here, this intersection does not have a light. So turning left out of there is going to be a little more difficult for you, especially depending on what time of day it is. So what you can look at doing is as you come back out Elm Street here, coming down to Purnell, and then Purnell will get you up to the service road, and then you could use the turn signal there at Main in order to turn left and get back into Flower Mound. Okay. So this is a look at that lot, what it is right now. This is all handicap parking that we have with our helo pad right over here. We're going to take all of that handicap placards down, put EMS ambulance parking only for you guys in order to really exaggerate the fact that we're not supposed to have any other parking than you guys over there as well. And let me back up a little bit here too. So since you're going to be pulling up and pulling down through the pylons, it's a pretty narrow area. You can fit 2 ambulances next to each other, but the other ambulance is not going to have the right turning radius in order to get out. So we're going to have to look at doing it one at a time. So as you unload a patient, try to be mindful of those that are behind you and really expedite moving of the ambulance back over into the staging area so others can get in behind you as far as that goes too. Now, since you're going to be a little bit further away from the awning and further away from the emergency room staff and that, we are going to have a security guard placed out here 24/7 in order to make sure that those ambulances stay safe since they're going to be a little bit further away. Also, part of that security guard's job is going to be to promote flow of traffic because that's still going to be where our patients are pulling in to drop off. Maybe grandma can't walk, maybe grandpa's having an issue. Absolutely. We'll pull that patient out of the vehicle, assist them into the ER, but they're going to have to promote, okay, now that they're out of the vehicle, we really need you to move this car. This is our primary means of getting ambulance traffic in and out, and you're right now blocking the way. So we're going to promote that flow. We're going to keep your ambulances safe.
If there is like a active available, go back to that where the handicap, is that where you want us to? We can offload there if there's, say, you got a couple ambulances lined up.
You could absolutely park there because we are still going to have.
If we got a critical patient, we can.
Certainly. And that's one of those things that we're going to kind of experiment and play with because we've really tried to see all the different situations and scenarios that we're going to have, but obviously, we're going to run into some stuff. 3 ambulances, 4 ambulances come up. What if someone's unloading a car as well, type of thing. And we just really ask you guys to try to be flexible as we go and think of other things that can make this job easier. If you're finding that you're dropping patients off right here, if you're having to pull in and then walk across the street, go up the ramp, if an awning type of thing, a walkway would beneficial, type of thing if we're experiencing a lot of rain, anything like that, go ahead and communicate that with me and let me see what I can do and we can start getting those things in place because again, it's going to be October of 2015 before all this is complete. Yes.
Josh, can you go a couple more slides forward to the overview, please? Oh, here we go. Okay, so the parking lot to the direct south of the ambulance bay right there, was that?
Oh, this one?
Will we be able to drive through that parking lot to exit? Sometimes we'll follow the ambulance in a fire truck, something like that.
Okay.
And instead of, is that going to be a dead end for us, or can we have a chance to pull our way out, or is there another a good spot for a fire apparatus to pull?
Sure. So the engine's going to be pretty big as far as that goes. This yellow area we want to try, it's going to be a really tight turn as far as getting an engine into there goes. There's a gate here, and part of what the security guard is going to do is that this gate is going to be open as well. So you guys could look at pulling in right now. This is all employee parking, and this is a really big parking lot. So you could pull into there. I've talked with Jim a little bit to have these gates open as well, so you could essentially just pull right through into Purnell. He hasn't got back with me yet on that, but that would be a really good option for you. Also, this parking lot is really big to where if you did have to loop around and come back out, there's a lot of space there. All along this area, Elm is pretty wide as far as the street goes. This is our engineering building, and you could park in front of that if you had to. And this is a loading dock that actually goes in, and that's where our 18-wheelers turn around. So I think if they can turn around, you could probably do it in there if you had to. But it looks like your best option is going to be to probably pull in here. You could park over here along the median, and then you have all of this entire parking lot area that you could use to manipulate around.
So you said a gate. Is that an armed gate, or is it pretty wide, or is it going to be restricted to driving?
Right. So it's a tiny little hip-high arm gate here, and then on this side of Purnell, they're just swinging gates, and they would just pin back, and then there's nothing in the middle as far as because your turning radius gets kind of tight as you have to go left and right with that as well.
So are we confirmed that we're going to keep the gates open for them down near Parnell?
That's
Is
what
that confirmed and they go?
Not on the Purnell side yet. I've been asking to try to get those gates open so it would be a pull through, so we wouldn't have to worry about the turnaround since we are going to have a security guard out there, but Jim hasn't got back with me on that yet.
Thank you.
So this is the location of our new emergency room, which is going to be that entire shot. Right now you guys are pulling in over here, pulling up into the emergency room. So all this is all going to be under construction. We're going to be coming out all the way to the sidewalk, bleeding down around there. And then it's going to go all the way up to the front where our main entrance is. We're going to mimic that exact same look. Okay, so it's going to look like we have almost two main entrances. Have any of you been to Medical City Dallas to see how their ER is kind of set up? They have a specific peds entrance and an adult entrance, and we're actually looking to co-brand with them, and we're going to have our entrance look the same as well. We're going to have pediatric services on one side, adult services on the other, to kind of separate those two out. And it'll be a very continuous type look, mimicking what we already have there for the main entrance of the hospital, the triangle that comes out. Okay. This is a view from the construction pad looking out to 35, just so you have an idea of where they're sitting, where they're going to be all set up as far as all of that goes. And then I've got a couple of other things here that the lab asked me to bring up with you guys. And what we're doing as far as blood draws goes, they want to really promote you guys, congratulate you on doing blood draws for us. It's really helping us quite a bit here. And they just wanted to give us a couple of tips as far as the tubes go. So fill, the one thing, they really want the green top filled all the way up, but if you just fill all the tubes as full as they'll allow, that'll be great. The additives that they put in there sometimes require a little bit more blood than less in order to get the really accurate results. So just fill them up as much as they'll take. Your results are coming back on average, if you draw blood in the field, in less than 45 minutes. So if you just to get an idea of what time frame you're looking at, if you were to walk in through the ER doors, check yourself in, be seen by the nurse, get triage, seen by the physician, get your blood drawn, and then we'd get those results back. We're looking at somewhere between an hour and a half to possibly 2 hours on getting those results back. So you guys, by drawing blood in the field, it's cutting that time almost in half. You guys are doing really awesome. So keep up the good work as far as that goes. Sometimes if you're drawing blood and it feels like it's kind of vibrating or coming out really, really fast, what they kind of told me to do is, and there's not really a better analogy other than pour it like a beer. Okay, you can manipulate the blood tube inside of the hub there, angle it off to one side where it kind of trickles down the wall, and instead of it just really, if you got a good 18, if you got a 16 type of thing, that blood's really pumping out of there. If you have it just kind of run down the wall, that helps keep the blood specimen really, really good too. And remember guys, that time is muscle, time is life. Whether we're talking about strokes, we're talking about heart attacks, the faster we can get this information, the better care we're going to provide for this patient. So keep up the good work as far as all that goes. Also, on Wednesday the 24th, we're having a groundbreaking ceremony for our new emergency room. Whether you're on duty or off, I'd like to invite all of you to come. I know Chief Trimble has forwarded out the email that has our little flyer and brochure on it type of thing. Swing by, it's a good chance to meet. The hospital executives are all going to be out there, photo opportunities, all kinds of people are going to be there just to get an idea of what the blueprint is going to be, how the footprint of the new emergency room is going to be. All of that's going to be available for you there to get an idea of our new 24-bed ER that we're going to be getting. And it's really overdue. It's great. The community's really grown up and the demand is absolutely there. And we're going to be able to start providing excellent care. We're going to have a brand new facility for all of this. It's really going to be an excellent chance to come out and see what we've got going on over at Liz.
Talking about the blood again, is there, because I think we've had some confusion, is it same tubes for stroke versus MI?
Yes.
Exact same, so those the baggies, it's 3, is that correct?
The green, the blue, and the purple is probably the
And
three.
you use the same one for sepsis too. If you are trauma, if you think this person's going to need a blood draw, use the
Do
same
all
thing.
3.
Absolutely. And as much as they'll take, like the purple one, it stops about halfway up. And that's just the pressure that's in it. That's fine. The green one should get most of the way full, and then the blue one should as well get most of the way full as well.
And you're good if we, on that bag, write name, date of birth.
Do
I know the tubes can eventually get, I mean.
Right. Do your best to put your patient identifiers on there type of thing. I understand it can be a little tricky. You don't exactly have the bedside labels. Something that when you pull into the emergency room, you can go, yeah, this is this person's blood. Verify it with another staff member. Then we can get our good label on it. And you guys are awesome.
Okay.
So a couple of tips, really as we're going forward with this, we've really got to have great communication with you. So I've changed a couple of things here. The first thing is we have a comment box in the EMS break room now. It's the red box that was there. I've got some comment sheets next to it, and that I want you guys to use for everything. If you want a patient follow-up, of course, use your chain of command. We're going to keep everybody in that loop as far as your patient outcomes goes. but it's also things as far as, there's no water, type of thing. We need some more water down there. If you have a comment or a concern as far as nursing staff goes, physician staff goes, praises are always good too. Hey, it was great. Jennifer took a report from me. It was really quick. It was, very efficient. I appreciate what that's going on, as well as concerns of, it looks like the nurse kind of blew me off, didn't listen to my report. Their back was to me all the time. I want to know about as much as possible that what I can do to get things better for you guys. Okay, so concerns, praises, all of that can go in that box, and I check it daily. Okay. The other thing is that we're going to have a lunch and learn here in October. Depends on how fast the groundbreaking is going and what stage we're in, but we really want to hear back from you guys. What are we doing well? What needs to be improved on as far as traffic flow goes? Is there anything we can do better? Maybe change some things up. Look at our one-ways being a little bit different as well. So I'll have more information out to you guys and email Chief as soon as I get a good date on that one goes. Please remember to be respectful of those behind you as we're going through this construction phase. Move the ambulance away quickly here. And remember, we're going to be funneling everything from Edna over into Elm. Now, that period's only going to be 8 weeks. Once Elm Street is all done, then Elm Street will open back up, and we're going to explore some other options as far as traffic flow goes from there. The other thing is that the construction company told me 8 weeks. That's not necessarily a hard set number. Once they get in there, they start looking around. We're talking about old sewer lines, old storm drain lines, old gas lines, electric, telecom, all of that stuff runs under Elm. We got to move all of that. So as they dig deeper, if they find more issues, it might be a little bit longer than that 8 weeks. You can always call me. My phone, my door is always open. Shoot me an email, any concerns, anything like that whatsoever, especially during this year as we're growing and we have all this process going forward. I think really communication is going to be the key in order to make sure that the flow is as good as possible for you guys. Okay? Any other questions as far as the traffic flow goes, the construction goes, any ways of getting a hold of me goes, before I hand it over to our other people here? All right, guys. That's all I've got. Van, do you want to go? Sure. There you go. And the clicker works if you need the clicker. And it's that mouse that works. The black mouse.
Blair. My name is Van McKnight. I'm the AVP of Cardiovascular Services, and basically includes the cath lab, the dialysis, and several other areas. This is a one that we did at a lunch and learn a couple months ago, and it was an outpatient, so it's not an emergency patient. She came in electively, and we were going to angioplasty or stent her LAD. Her LAD is going up over the top, and there's some stenosis kind of at the end of the pointer, and I'll get a better view of it for you. But what happened when we opened up her LAD is the artery perfed, or we put a hole in it, and you'll see pictures of that. And what it basically does is we're creating tamponade. So like if a patient hits a steering wheel, or they have cancer or tumor in their pericardial space, and the fluid starts leaking out into there, this is an acute event. And she dumped 1.5 liters of fluid in their pericardial space before we could get it sucked out. But you'll see the effects on the left ventricle and the cardiac output. You'll see the blood in contrast pooling there in the aortic root, and I'll point that out to you when we get there. I think she's probably a 50-ish-year-old female, came in, had a positive stress test, and just diagnostic cath. So this is the LAD. This is the one that comes down the front of the body, right down the front wall. And you can't see the blockage here, but it's right behind in there. So it's coming out towards you, so you can't particularly see it in that view. And the name has been redacted off. That's not the true date of birth either. So right there, where it narrows down significantly, that was causing chest pain. She was having night sweats and chest pain, couldn't walk, couldn't do much anymore. It's very lethargic, kind of that typical female presentation. And you see her vessels are very small, and they're also real tortuous, or real look like a curlicue, the snake river. That's kind of typical of high blood pressure. Here again, the vessel, the blockage is right over here. The next picture I'm going to show you is her right coronary artery. Not like brand new, but not any significant problems that need to be taken care of at the moment. So we put a balloon, which is the dark long object, right here. And the wire is going down the LAD. And this is just a picture just to document that their balloon is blown up in the artery. So it's just real quick on and off the pedal. So it looks real fast, but it's really not. First inflation. Took another picture. Everything looks okay. You can see the balloon carrier is still right here between these two little dots. Got the stent in place. It's a little darker on the wire there. So far we've just done the balloon just to open it up so we can get the stent down in there easier. The stent's inflated. And this is like, uh-oh. So, all this contrast out here going back, that's some draining into, and I can't remember the name of the vein, into the right atrium. So it's going back the normal channel. However, blood is dumping out into the pericardial space. So if you think of it like a boa constrictor, when you take a breath in, it squeezes more, and then you try to when you breathe in, it squeezes more, you breathe out, you can't breathe out as much. You take another breath in, just keep squeezing. So the pericardial space is just continuing to fill up with fluid. Right here, the heart is still pumping okay. You're not seeing any pool of contrast right over here. So the left ventricle is ejecting the blood contents. But there's no blood going down the LAD, and it's spilling into the pericardial space. Now look at the blood right over here, and in the aorta, it's just kind of pooling and sitting there. It is squeezing a little bit, but there's no forward cardiac output. And you can see all the vessels have kind of clamped down. So she's in a significant amount of problems right now. We still have the wire down the vessel, the little coronary wire. You can see the dark spot right here. We put a balloon back down there and inflate the balloon so that blood will stop exiting out the coronary artery. So we're tamponading that artery. We're giving her a heart attack, basically. But you remember, we have 90 minutes, right? So if you have a blockage out in the field, we have 90 minutes to open it. So we immediately called the surgeons. They came in. We left the balloon inflated, so no more blood was leaking out into the pericardial space. We have this big tube coming in. It's a pericardial catheter. We come in subxiphoid, and we snake the catheter around the heart, and we drain that fluid out. We've got the balloon inflated right up here. So we're tamponading off the LAD. No blood's going out the hole. And we've got this tube in draining. And so the LV picks up and is getting better. You can see the contrast, or the dark materials exiting out the aorta. Almost like normal, not quite. But she did okay. She went emergently to CABG. So this is one of the benefits of having a PCI program with a bypass program in the same place. Otherwise, some places would have to transfer them to a place that does CABGs. But she went emergently to the OR, I think it was 40 minutes or so, and they'd already split her sternum and bypassed the vessel. So it was a real quick on-pump type surgery. She did fine. She went home about 3 or 4 days later and was doing great.
Is that, how rare is that?
I've seen, in 25 years, I've seen 2 vessels perf like that.
Pretty rare.
So it's pretty rare. That's why it's safe to do PCIs out in, say, West Texas, or I don't want to say Decatur, but in the middle of nowhere, because the chances of this happening are very rare. We used to have balloons that had a Gore-Tex covering on. I'm sorry, stents that had a Gore-Tex covering, so we could put a stent in there if this kind of situation happened. With a covering, inflate it, and it blocks off that channel.
Places that do this, do they always have a surgical staff ready or kind of, if it happens?
We used to years ago, but it's with the advent of stents, it's really, really, really safe now. However, these kind of things happen, and we do have surgeons on call 24/7. So they have a 30-minute response time. Anesthesia, cap coronary bypass techs and nurses and heart room staff, perfusionists, they're all with the surgeon. So in case this event happens, we can take care of it. But in the field, patients can get cancer, and fluid can leak into that pericardial space and cause the same kind of situation. When it's cancer like that, it's going to be a slow leak, so they become accustomed to it. Whereas if they hit the steering wheel in some kind of acute event, what else would cause it? A knife wound, of course, that kind of thing. You'll see this happen. But the ones that have cancer or tumors, and it just gradually leaks into there, they're used to it. They just know something's not right. They just think it's probably their disease. So I've seen almost 2 liters of fluid come out of the pericardial space, which is a ton of fluid. That's the most I've ever seen. Any questions or anything unanswered?
Interesting case.
Yeah, this wasn't an EMS case, but it was pretty interesting to see the effects of the LV and lack of blood flow to the coronaries. Thank you very much.
Thank you.
All right. Well, I'm Jennifer Turner, and I'm the new trauma coordinator for Medical Center of Louisville. I took over for Amanda Rivera. I don't know if any of y'all have met her. I've been at Louisville for 5 years. I've worked in the ER as a staff nurse, was clinical supervisor, and now I'm taking on this new role. So this here is just a kind of a quick overview of what we do as a level 4 trauma center. Basically, for a level 4 trauma facility, we are here to stabilize and treat patients, and then if they need to be transferred to a higher level care hospital, we expedite that. We have all of our doctors are getting certified in ATLS, that's their trauma certification, and then our nurses are TNCC certified. So these are kind of the state guidelines that they want us to have to take care of trauma patients. We also have our trauma activation guidelines, which I'll go over for you, and then we have our trauma activation team. When you walk into, when you bring us a patient, we would like to have, this is how we want our room to be set up as far as where we want all of our personnel that's in the hospital that responds to a trauma. At the head of the bed, we want our ED physician. We'll have RT respond. We'll have radiology respond, lab respond. We have 2 RNs. You have your primary nurse. That'll be kind of hands-on with the doctor. They'll help do the assessment. And then we have a nurse that's a recorder. And then if we have a tech available, they'll be in the room as well. when you come into a room, and this is something I'm really gonna start working with the nurses, when you come into a room and you bring us a trauma patient, we want the room to be quiet so that we can hear y'all's report. I know it's exciting and everybody wants to be in there to see what's going on, but we really need minimal persons in there to get the full report, to understand what's going on, what y'all are bringing us, and what we need to do to take care of this patient. We have 2 different activation levels. Level 1 is our highest priority. These would be like our penetrating wounds and our unstable patients. Level 2 are the most common. There are falls, MVCs that have stable vital signs, and really our activations are the level 2s that we get that are the most common that we see in our ER. This here it's a lot. I'm actually working, I don't know if y'all have these, Amanda had made these up. They're little cards that you can wipe off, you can keep on the ambulances, and they actually have our level 1 and level 2 trauma activation. So from y'all, if you go on a patient, and one of the biggest ones we see are, elderlies who fall and they're on blood thinners, those meet our level 2 trauma criteria activation. If you run on that and they're stable and y'all are going to bring them to us, please feel free to activate in the field. By activating in the field, this gets all of our staff members here in the ED present before the patient arrives, which allows us to expedite the care. If you can always activate, and then it's up to the physician's discretion if they want to cancel the activation or not. So there's no fault in activating or not in activating. When y'all call us and we get the report from you, we actually have this right next to our phone. So our nurses will, as you're telling us what you have, we'll look and see, is this a level 1, is this level 2, and our nurses can actually activate if y'all don't do it from field. I'm going to also work with them as far as scripting, because there's certain things that we do need. MVCs are a big one. How fast were they going? Sometimes, they call and I know it can be busy and they can kind of rush, like, okay, yeah, what you got, but we really want to work on asking those key questions for you to give us that important information to allow us to activate before y'all arrive. So I'll get these. They should be coming in this week, and I'll get these out to y'all so you can keep them on the ambulances, and you can have these for your knowledge. These are kind of just some facts that I found. Unintentional injuries is the leading cause of death in the U.S. for people between the ages of 1 and 34 years old. Nearly half of all traumatic incidents involve the use of alcohol, drugs, and other substances. So just kind of key facts right there. Our mechanisms of injury, we have blunt versus penetration. A lot of those will be our level 1 activations. These are vital to the initial assessment, so these are what y'all are going to see. When you go out, you're going to see if it's a blunt injury, is it a penetration injury. If you do bring them to us, if they're unstable and y'all can't get them to Parkland or a bigger hospital, and y'all bring them to us, we can stabilize them in our ED, and then we'll work on shipping them out to Parkland or Plano, wherever they need to go. This here's the case review that y'all brought in. I believe it was in the beginning of August. So he's 25 years old. He was a restrainer driver in a single car rollover. He was self-extricated and was walking down the side of the road when y'all arrived. He complained of the head pain, felt like he had glass in his eyes, and shoulder pain. Initially, he did not want to come to the hospital, but after I guess the guys talked to him, he then agreed to go. Y'all put him on the backboard and C-collar, and then you came to us. Things that we look for are vital signs. This here is a really good job of all the vital signs documented. The GCSs are important, and also the RTSs, the revised trauma score, is important for us. When I do chart reviews, these are things that I look for to put in our state registry that keeps track of all of our trauma patients. So having these here are a big benefit to put into the registry. Also, your call times. This is another big thing I look at. I look at from when the call was placed to when y'all arrive to when you actually get to the patient, and then how long it took you to get here to the hospital, and the total call time. So this call time was 33 minutes, which was really good. We activated prior, from the report that the nurses received, we were able to activate at 23:53. And then y'all actually arrived at 0:02. So we had everybody there ready to go when that patient rolled in to get x-rays, blood work, everything going. So by early activation, we're able to give the patient expedited care. That's the big thing with trauma patients. After the patient was evaluated, he just had an abrasion to his left shoulder. We gave him a tetanus shot. I believe he refused all x-rays in the ED. I don't know if he was super cooperative when he got there. We did a little wound care, and he was discharged home and walked out of the ED. So that's it, really. Do you have any questions?
Is there a time frame? If, let's say we transport somebody and then you guys decide that y'all need to transfer them, do y'all have like a window that you guys try to, an hour, 30 minutes?
We want all of our trauma patients out in 30 minutes if we need to transfer them. So we have our transfer center that we use if we need to fly them or by ground. If we come in and we need to send them to Plano, we can call our transfer center and they'll send us an ambulance. I know Louisville and y'all, if we're here, we need to get them out. If y'all are available to take them, you know, if you bring them in and they just crash in front of us. If we need to take them and you have a unit available, then we could do that as well. But usually 30 minutes for AMR or care flight to come. Is that it? Question? Oh. Very well. Technology.
So again, my name is Patricia. I'm the stroke program coordinator. I think I've seen a lot of you guys coming in. I usually try to come down when there's a stroke that's brought in. I want to first of all start off by saying with the fairly new initiative of you guys drawing blood on a pretty consistent basis for us has made a huge difference for our patients. And I can speak specifically for the stroke because I place my hands on every chart. I review them all and I try to kind of see opportunities for our facility to provide better care or just to help promote better outcomes. So I wanted to bring you two patients today, both which were brought in from Flower Mound. This person, patient D, woke up, it was a female, woke up in the middle of the night, early morning, went to let her dog out, kind of recognized she couldn't move her arm when she went to open the door, then couldn't walk very well, crawled to the couch, called 911, and your team came. Apparently, I followed up with her in rehab. She told me the story as it finally came back to her, that the team that came, apparently when they walked in and they saw her symptoms, one of the medics actually said, "This is a stroke, let's initiate a code stroke." And that stuck in her head. And she said, "I think that's what helped me know I was gonna be okay." And then I think when she was in the back of the box, they put on the lights and sirens. And she said, "Well, I guess you're going to charge me extra for the lights and sirens." And she said because she had her humor and the guys were willing to joke back with her, she knew she was in safe hands and that you guys knew what you were doing. So just the presentation of the way that your team handles when you go in to take care of these patients, and you're getting them on the stretcher, and you're drawing their blood, you're reinforcing that they're safe. And that's a huge thing. And I want y'all to know that they remember this and they tell this story over and over again. So brought her in. She was a candidate to receive TPA. From the time you drew the lab in the field to the time we had the turnaround, it was 42 minutes, which is amazing. We pushed TPA at 47 minutes total. So because y'all helped get us the blood and we could verify that she was a candidate and didn't have any bleeding disorder, we were able to start the TPA. So we initiated her, too many mouses, I apologize. So we initiated the what did I do? I apologize, gentlemen. What happened to the
Might have closed it out.
patient D?
I can bring it up.
Okay, pull up patient D for me. So we initiated the, you were using the clicker. Can I use the clicker?
Mm-hmm.
This one? Okay. So we initiated TPA. called our unit. We transferred her to Medical Center of Plano. When you brought her to us, her initial NIH was an 8. Did you find it? Okay. Was an 8. When she, thank you very much. Which one is?
The right arrow.
This
That'll be
one?
forward.
Okay. When she arrived at our hospital, she was an NIH of 8. Now, when we talk about an NIH on the hospital side, that kind of tells us how severe the stroke is. It also gives us an indication on how large the vessel is that's being occluded. So the magic number for us is 8 on the NIH scale, just like on your GCS, less than 8 intubate. With us on an NIH, if you get an 8, we start thinking large vessel, which means you might just be a candidate for intervention. So we contacted our neurologist over at Plano. They agreed she needed to be assessed for intervention. So what intervention is, your Plaza, Medical Center of Plano, now Medical City Dallas, and UT Southwest, we're all comprehensive facilities. And they have the ability to go in through the femoral all the way up to the brain with their little, you're going to get to see it in a second. They go in, they find the clot, and they pull that clot out, just like a heart cath, but we do it in the brain. They're awake, just like in cath. They're awake, they're a little sedated, but they can talk to you and tell you what they're feeling and seeing. So this is her initial head CT. There was no bleeding, which is good, no hemorrhage. When they did the angiogram, you can see there's a partial blockage. I don't know how he made the little light go. How'd you make the
Club in
little?
the center if you push it down.
Okay, so see that little dot right there? This is our infarct, okay? You can see here on the brain attack MRI, you can show that there's minimal injury, all right? But remember, it's not just the blockage that's dying, it's the area around the brain, and that's really what we're trying to save. And that area, if we can get the blood flow back, can be saved. Once tissue's dead in the brain, tissue's dead in the brain. All right, so that's why time is of the essence for us to be able to get in there and get that clot out. Here's the angiogram. This one is showing the partial blockage. Right here you can see, but you'll see that the blood is still passing through. So when they got in here, they realized that the risk for them to close off the vessel to remove the clot would actually cause potentially more of an infarct to the brain than to just let the blood go ahead and be able to get a partial through. So on this patient, once they got in there, they realized it would be more damaging to try to withdraw the clot. So they pulled out and left this clot in place. This clot, since he will be managed on blood thinners and different things like that, hopefully will not increase or in size. But if it did and he were to have another stroke, they might could then choose to go in and remove it. But on this particular patient, they recognized that the risk outweighed the benefit. On this piece, you can see it a little bit better. Again, it's just the showing blockage, but you can still see that even past the lesion on both sides, you're getting good blood flow. This is the physician's documentation here. There was good fast flow distally, so it was decided not to proceed with the mechanical intervention. There's always the risk of shutting down the vessel completely. It can just clamp down, basically, and if it does that, it's very, very difficult, almost impossible to get it back open. So they took him back to neuro ICU for post-TPA care and further workup. This gentleman left their hospital with an NIH of 0. So, full recovery with TPA, our turnaround times were great. They were going to try to remove it, couldn't remove the clot. But here's the nice part. He came to our rehab back at Medical Center of Louisville. He was there for a week. He did very good. His NIH was 0, essentially meaning there was no neurological assault. There was a part of his brain, however, that was injured. And that part was his ability to maybe not always make the best judgments. In his case, he would just randomly take his clothes off and walk around. So we work with him on that. They worked with him on that in rehab. They sent him to PATE, which is kind of a long-term where they go like daycare, where they kind of can learn that that's not appropriate behavior. And when I followed up with his wife about a week ago, she said he's actually not streaking. Yes. But if that's the worst thing the man does, he at least can have somewhat of a life again. So very, very thankful to you all. You all made a big, huge difference on this one. All right, on our next case, we actually did remove a clot. So I just shut this one down, Josh.
Yeah, sorry.
Did y'all have a question?
Was that a female or a male?
I think I told you it was the female. I think that one was actually the male.
Okay.
Okay.
Mate, okay.
Was it y'all? Does that make
No,
sense?
no, I
changed
thought it was
genders.
two, yeah, you
I
changed
just
it.
wanted to see if I were paying attention.
Yeah.
That one was a man. This patient had a right ICA occlusion. We did give TPA, mechanical thrombectomy. They used the Trevo XP. That's just one of the many tools that they can use to go in and remove this clot. CT of the head, you can see right here, the small lesion that they found. On the angio, right over here, oops, sorry, went back too fast. Right here, you can see the very small lesion. The MRI, little damage, but here's what I want to show you guys. You can see this is where the stroke is, but this whole area in here is the area that has reduced blood flow, reduced oxygen, and that's why your strokes can get worse and worse and worse if we don't get this fixed. This is just prior to the treatment. They got the microcatheter right here. And then, these are just, I mean, I'm not a neurologist, so I can only tell you what I know of, but you can see where they deployed the Trevo here. This is the AP view. A lateral view again. After they pulled it out, you can now see, you can see right there the lesion. And now it's open. You see the difference? Before and after. It's pretty amazing. I mean, who would have thought 10 years ago that we were going to stick things up into people's brains and remove clots? So, I think that's our last slide on this one. This gentleman, this was a female. You did labs out in the field. We had results in 40 minutes. We started TPA at 44 minutes. And then when they got to us, this person, her NIH was a 12. When she came back, she was a 2. So she didn't make it all the way back down to 0, but she went from having literally no movement to full movement. I think she had some speech deficit is what was left with her too. One of the things I want to mention though is I keep saying it's all about, you know, drawing the labs in the field, but it's so much more than just the labs. When you draw the labs and you call report in, I want to stress to you so much if you will initiate a code stroke from the field. And that code stroke is defined for anything less than 12 hours from the last known normal. All right, so if it's within 12 hours of the last known normal and you call us to give a report, please let us just say, I'm initiating a code stroke. You do not have to ask permission. Use your judgment. You guys are looking at it, you see it, you feel it, you touch it, you know. If it comes in and ends up not being a stroke, it's okay. There's no additional fee for that. Guess if you run lights and sirens, I'm just kidding. But you truly, if you call it and we get it and it's not, it's okay. If you don't call it and it is a stroke, all we will do is if there's something that maybe we could have educated differently on when we're out here, then I'll get back with Coach Trimble and we'll come out and we'll re-educate. But you guys are doing great, but I just want you to know to please call a code stroke. What are we?
Coach
Trimble.
Oh, Coach. Is that what I called you? Yeah. Why are we just calling Coach?
Put me in, Coach. Put me in.
That's right.
Yeah, throwing a flag.
I'm ready to play.
So, on our arrival, are most of the docs in, I guess, agreeance that just a quick neuro by them and then keep them on our stretcher to go to
CT?
CT?
It's an excellent question. That's all based on the flow of what's happening in our ER at the time. So if you call ahead and you call the code stroke while you're en route, we are going to have our CT team, who's part of our stroke response team, empty that CT, pull whoever's on there off if they can. We have 2 CTs, or we can open up the second one. So in those scenarios, by the time you hit our door, if they've been able to remove the patient, they're going to try to go straight to CT. Have a lot of you done that yet? Have you gone straight to CT? Sometimes, however, if the CT tech is tied up on another bed or another area and can't come to do it right that second, we'll pull them into the room. We'll do a quick NIH, and then when CT is available, we'll take them then. So a lot of it depends on the flow of the ER at the moment that you drive up.
Should we be I guess, asking if CT is available?
No, you don't have to. We have, best practice is to have a CT within 45 minutes from the time you hit the door. So by us being able to have it available right when you show up, that's just icing on the cake. We will always, and we 99.8%, I think was our last time I reported our data, we were at, I think our from door to turnaround is 23 minutes. So we're way below the requirement. That's an excellent question though. But no, CTs are never an issue. Okay? Yes, sir.
What's y'all's protocol for transferring your stroke patients out?
So at Medical Center of Louisville, we are what's called a drip and ship facility. We initiate TPA and we transfer them to a higher level of care. And I want to pause there for a minute because you might be thinking, why would I stop? Why would I stop and let you do something for you to turn around and then transfer them out when I could have gone straight there and got there faster than you? Here's why. When you stop at Louisville, you can ask me. Did you want to?
No, I was saying, I was gonna answer the question.
Oh, okay. Go ahead. Answer the question.
Time is brain.
Absolutely, time is brain. But when you stop, see, he got points for that. When you stop and allow us to get the TPA initiated, immediately the brain is hopefully beginning the healing process because the blood is being thinned to get some blood around that clot. TPA does not dissolve a clot. The only thing that gets the clot gone is that they go up and they remove it. But what TPA does is it thins the blood enough where it can open up and get the blood around the occlusion. Okay, does that make sense? So that's why you stop at your closest primary facility. It doesn't matter to me where it is because it's all about the patient's outcome. But the closest certified stroke facility so they can get the TPA going. Usually by the time we start that TPA, we're transferring them within 10 or 15 minutes. I mean, it's a fast turnaround. But then all the time they're transferring to the next hospital, they're getting that medication that's already started to work on the stroke. So that's the reasoning for not just bypassing and just booking it on there. Okay. Any other questions?
When we draw blood, does our blood go to the front of the line when you send it to the lab?
Absolutely. When you call us, and even if you don't call the code stroke from the field, let's say you're not real sure, they're kind of altered, but you draw the blood, you bring it in, and the staff decides or the physician decides we're going to initiate a code stroke, that blood automatically gets ran to the lab. It's just like doing a CPR. It's an attack on the brain. So everything is pulled off the lab and ours go first. So yes, your blood will always take priority. Because you guys you're not bringing me a lac with blood. That might not jump to the line, but you're bringing me an MI, you're bringing me a trauma, you're bringing me a stroke. Absolutely it is. Absolutely. And when you call the code stroke ahead of time from the field, the lab is also paged. They're on our stroke team. They start pulling their labs off of their off of the spinners so that the minute they get our lab, ours go on. So we've got it pretty streamlined.
What
Yes.
percentage of head bleeds stay with y'all versus to death?
We do not keep any sort of a hemorrhagic stroke, all right? If you bring us, that doesn't mean you have to bypass us because we can certainly stabilize and follow the same protocol that Plaza, because their physicians are our physicians. We use the robot. We'll help get them stabilized if we need to and transfer them. But we do not keep hemorrhagics. The reason is because we do not have a brain suite to go in and open up the brain should we need to relieve pressure, and we do not have a neuro ICU. Okay. All of our stroke patients, just so you know that our care is continuous, the strokes that we keep at our facility go to our PCU, which also duplicates as our stroke unit. Those nurses are specifically trained for stroke care. They're not just, different, a tele nurse or what have you. Tele specializes for cardiac, and they specialize for the brain. It's a good question. Any other questions? No?
Thank you.
Sure. Courtney, was there anything you can think of that I could throw in there? No? All right. Well, then I guess Ms. Courtney will come up. She's our sepsis coordinator.
Okay, my disclaimer is that I get really nervous when I speak. So bear with me, and if I start going too fast, tell me, please. Okay, so I'm Courtney. I've been at Louisville since, I guess, June. My background is all critical care. I've worked neuro ICU at Harris, Fort Worth, at Parkland, and then I started working CVICU down at Plaza. And so I've taken on this role. I've been in management before, and this is really a different role. You get more hands-on with the patients and the nurses, and not quite as much of the administrative stuff. And that really is going on here. So if I can work this thing. So what's our mission? To reduce the mortality associated with severe sepsis and septic shock, and by using goal-directed evidence-based practice modalities to do so. Goals. So for severe sepsis, the mortality rate, they want us to be less than 20%. We have achieved at Louisville less than 8%. Theoretically, if you're passing away from this, you should be in shock, so you should have a low severe sepsis rate, because if you're passing, you would be in shock. So septic shock mortality rate, our goal is less than 30%, and we've now achieved 25%. When I got here, we were 44. We've progressively gone down. Overall mortality rate, less than 25, and we're at 17. So sepsis screening upon ED triage, hospital admission, shift assessment, and condition changes. And so that's a screening that we're going to go through here in a minute. The nurse's screening is a little bit different because the one I could pull up was from the CDC, but it goes through the same kind of steps. And then sepsis, a 3 and 6 hour bundle compliance, and we're at 57% right now. That's up from 37. It's also due to the implementation of EDM because the scanning rates and those kind of things counted in as far as when the first IV fluids, the antibiotics and all of that. We weren't capturing that with TB. So we're hoping to see that progressively increase. I put that in yellow. It doesn't really look yellow. It looks green, but it's not red. So what are you looking at with sepsis? So we have systemic inflammatory response syndrome. That's basically a clinical response to any kind of insult to the body. So it can be non-specific, it can be infectious related, it can be traumatic, and those kind of things. It's defined as a fever of greater than 100.4 or less than 96.8, heart rate of 90, greater than 90, respiratory rate greater than 20, or a PaCO2 of less than 32. Basically, if your patient is not compensating on greater than 90, the stat with greater than 90% of oxygen, then that's where your kind of PaCO2 comes in. Or abnormal white count, so greater than 12 or less than 4. It can be caused by ischemia, inflammation, trauma, infection, or several other insults combined. So this kind of gives you a synopsis of what sepsis is. It's in the middle. You got SIRS over here. You can have burns. You have pancreatitis. I think this says trauma over here or other. So these are just any kind of insult that happens to the body. Then you have infection added in. So you can have a bacterial, fungal, parasitic, anything like that. So if you have that added to the SIRS, then your potential here is for sepsis. Doesn't mean you always have it, but it can. You cannot have sepsis just with SIRS alone. You have to have infection.
I'm sorry,
What is SIRS?
What is SIRS?
So SIRS was that's this one.
Okay.
Sorry, I think it's over here to the side. I apologize. So that's the systemic inflammatory response.
Okay.
So that's this here, and then you add it to the infection. In the middle, you could come up with a sepsis. Okay.
On the temperature, is a low grade or below normal, is that worse than having an actual temperature? Is that like your body just...
It's basically that your body's in shock. So at that time, there's a lot of times when you get patients in that they haven't compensated well, they haven't gotten enough perfusion and those type of things, and they actually go hypothermic. So that patient now is not compensating enough to even be normothermic as far as brainstem, anything like that. So they're not able to control their own temperature. So that patient is just as sick as your hyperthermic patient. It's actually probably sicker. Okay, so sepsis, presence of infection with the systemic manifestation, so that would be the presence of infection with the SIRS criteria. Doesn't always mean they're septic, but it's those two things together. Severe sepsis is sepsis with sepsis-induced organ dysfunction or tissue hypoperfusion. So if you have a patient that isn't able to void, if you have a patient that isn't able to hold their blood pressure, those type of things, if it's an end organ dysfunction, it's related to the infection, then that patient is in severe sepsis. Septic shock is where it's hypotension. It didn't matter how many fluid boluses you gave them, you got to put them on a pressor to keep their blood pressure. So a systolic of less than 90, MAP less than 65, or decrease of 40 points. So you got a patient that normally runs 160 and they're 110, that patient's hypotensive for them. So that's something also to keep in mind. So who's at risk for it? Is your patient have a known or suspected infection? So this goes through all of the different ones that you could have, plus a multitude of others. But the basic ones: pneumonia, skin infection, endocarditis, osteomyelitis, meningitis. Do they have wound infections? And those type of things. The UTI up there. So your most common are going to be your pneumonia and your UTI patients. Immunosuppressed patients, so your oncology patient, your patient with HIV, your patient that's had a transplant in the past. And then any of the autoimmune disorders, because these guys are generally taking some kind of immunosuppressant also. Sorry.
Don't forget to breathe.
Trying.
It's not
like being recorded.
I know, right? Well, it's funny because I was telling Josh earlier, I was like, I had to take speech, and I actually quit college and went to the Marine Corps just because I had to take speech, and whatever. So, patients with kidney and liver disease, so these patients are already immunocompromised, they have a lot of comorbidities and things like that. Patients with a history of alcohol abuse, multiple comorbidities. If they have any kind of access, so do they have a dialysis fistula, do they have a central line, were they home getting antibiotics on a PIC or a sniff or something like that. Recent surgical procedures, or patients that are greater than 65 or less than a year. So this is off the CDC side. So this is the screening, and basically it goes through what we just talked about. Is the patient have any suggestion of infection? And then it goes down through here. What it does for Meditech is it asks them a yes or no question, and then they screen yes or no, and then they go off that. Or do they have any of the following signs or symptoms of infection? So hypothermia, hyperthermia, altered mental status, tachycardia, tachypnea. I don't know if y'all are getting any of this off on the truck or not, but these are things that we're looking at. Their white cell count.
Sugar.
Do what?
I said blood sugar we are. But
Your blood sugar, yeah.
nothing, no.
So blood sugar, because basically if you have a patient with infection, they don't have diabetes, then a lot of times you're seeing those glucoses going up because they're basically feeding that infection. Bacteria love sugar. So those kind of things. So the organ dysfunction. So you're looking, obviously if they can't keep their blood pressure maintained on their own, then they have some sort of autonomic, or they have some kind of cardiovascular problem. Your urine output, lactate. So what we'll do whenever they get there is we're pulling a lactate, we're sending it off. If it's less than, or it's greater than 2, then your thought process there is they're not getting perfusion to the organs. Coagulopathy, so if they have INR, PTT that are elevated, acute lung injury, and again, this kind of goes into if they're not able to keep a SAT of greater than 90 on 2 liters of oxygen, then they're probably not, they're respiratory compromised. Okay, so this is the bundle. These are the things that we have to complete within 3 and 6 hours. Basically, this has all been, it's all evidence-based practice. You do these kind of things, and you treat the patient in this manner, and they have better outcomes. So for the first 3 hours, it's measure the lactate. You obtain blood cultures before you give them the antibiotics, and then you administer broad-spectrum antibiotics, and then you do 30 mils per kg of your crystalloid. Within 6, if they haven't responded to this fluid challenge, then you go ahead and you add vasopressors. For us, it's levofed and vasopressin. In the event of persistent arterial hypotension, then we also measure CVPs. We get a CVC place, and we measure CVPs, and we do SCVO2s as needed. And then we re-measure lactate. So for us, we do it every 6 for 24 hours. So why do you do all of this? Antibiotics, you shoot out a broad net, you reel it in, and you get the smaller finite infection. So we're treating that broad spectrum with the antimicrobials until we identify the source. The blood cultures, we need those to identify that. So if we start the antibiotics before we do that, then we may have lost the source by doing that. Fluids, tissue and organ perfusion, and then you also reverse the acidosis. Vasopressor support, again, after the fluid challenge, if they're not fluid responsive, then you're going to have to maintain tissue and organ perfusion. Lactate determines if the body is converted to anaerobic metabolism. So lactates, why do we do those? So lactic acid is basically showing us whether or not they've converted from oxygen, using oxygen for metabolism, or now they're basically relying on their body. So what it happens is that the tissues start to use glucose, convert it to lactic acid, and the whole Krebs cycle thing that none of us really want to remember gets screwed up. Because now they're using the lactic. The lactic is an offshoot of all of that, and basically your liver is now trying to process that out and oxidize it back to the glucose. That's why your guys with liver dysfunction, ETOH, all of that, they may already have high lactic acid levels because their livers don't work, so they're not oxidizing it normally anymore. Okay, so other situations where the lactic can be elevated. Any patient, so your cardiac arrest, your trauma patient, any kind of shock patient, those guys are going to have lactic acids that are elevated. Diabetes, patient with DKA, chronic severe ETOH, hepatic dysfunction, your leukemia and lymphoma malignancies. These guys already have, the proliferation of their blood cells is already screwed up, so they're already going to have lactic acids that are elevated. They're not using the same kind of mechanism for producing energy. And then you've got mitochondrial dysfunction, which also ties into your HIV infection, because the antiretrovirals that these guys take mess with the Krebs cycle again. It makes the mitochondria function differently, and then it makes that lactic acid offshoot. And then short bowel syndrome, so your colitis, your any of your malabsorption syndromes, those guys are going to have elevated lactics. Sorry.
Are all these patients in ICU for the 24 hours that you're?
Generally speaking, so the severe sepsis and the septic shock patients, these guys are really ill, and you'll see them, you'll know them. I don't know, I'm trying.
You're doing great.
You're doing great.
And this is going to be rebroadcast.
Again.
And again and again. So those patients are, because those patients are sick, you're going to look at them on the truck, you're going to know they're sick, you don't need all these criteria to tell that. You're not going to be able to get a blood pressure on them, they're going to be clamped down, and so they will all go to the ICU. Some go to the PCU if they're able to get them stabilized in the ER sufficiently with the fluid boluses and things like that, but in general, they're all going to the unit.
That's one thing I'm surprised we don't get in the field is lactates, to see where they are before fluids, dopamine, and
Right.
then to, yeah.
So
It's easy.
coming.
It's an initiative that's kind of coming along. It's costly because it's a different, I don't know if you'll use the iStat machine, but for iStat, that cartridge is a whole separate cartridge to run the lactic acid. And from what I've heard, it's costly. And so that's been something for different departments and things like that, that they're not.
They make lactate meters that are just like our glucometers.
Really?
That just stick, get your lactate.
Yeah. And so those are things, I know that there's different departments throughout the region that are investigating it. I think there's one closer to Dallas that's actually just running it on the iStat. But it is something to consider. It's not the end all and be all, like I said. You got other patients with comorbidities that could have, like I went down to, because there was a question of whether the patient should have gone to the ICU because they were admitting him to Teleon. Well, his lactate was 5.6, but he's sitting there talking to you, me and you just like this. He lives with that lactic acid, because if his lactic was 5.6 and he was in trouble, he wouldn't be doing that. So, and he actually ended up, he was ulcerative colitis. I mean, he even told them in the ED, I don't have sepsis, don't admit me to ICU. I mean, it was,
Wow.
yeah. I mean, he just knew. Yeah, he's done it before. So what is my role, other than standing up here wondering? Round on all the inpatients. I round on all the inpatients. I look at all the admissions from the ED. Well, actually all the inpatient admissions. And then anybody that meets criteria. I assist staff with coordinated care, patient assessments, transfer of care if they need to elevate their acuity. And then I do concurrent review of all the charts for the bundle elements. So we're looking at all of those things like when was the lactate drawn, when was the fluid started, when was the antibiotic started, blood cultures and things like that. Community outreach like I'm doing here. Collaboration with other coordinators within the division. We're relatively new in this whole system. They kind of did an offshoot of how stroke has been. And so what they thought was, okay, if sepsis is our highest mortality rate in hospitals, period, and we're starting to be looked at for our mortality, then we need to create these positions to kind of maybe get a handle on it, make sure that we're not having people die from it that we could have saved. Because again, these people are really sick, and a lot of them are your 80, 90-year-old patients from the nursing home. Sometimes it's not always about saving them, it's about giving them, a better end. Review of mortality cases for presentation at the sepsis committee. Collaborate with the clinical documentation and coding departments to ensure validity of the data. So just to kind of tell you how this works, I had an esophageal varices patient that ruptured. She got coded as sepsis, she didn't make it. She got coded as septic shock. Well, she had esophageal varices, that's an arterial bleed. She got 40 units of blood. Maybe she aspirated, but in 24 hours, how am I going to tell if she had pneumonia or shock? Or septic shock? So we were able to, go through clinical documentation and say, no, this is probably hemorrhagic. We need to change that around and go off that. So current projects. So we're doing nurse-initiated protocols. I've developed an algorithm because we all love algorithms. Developed an algorithm, and basically it's so that they can initiate that on the floor in the ED if they have a patient that meets these criteria. So if you guys bring somebody in off the truck, you say, hey, you know what, we think this patient's septic. We started our protocol, then the nurse can go ahead and roll into their protocol. Community outreach. So I'm gonna go, and hopefully they won't have me videoed, meet with the nursing homes. We've got 3 top nursing homes basically that we get admissions or admit to. Discharge to skilled facilities, rehabs, LTACs, and kind of give them some of the same information, because these patients generally that we're getting or seeing, a lot of them are nursing home patients, and they may have been there for a couple of days and they're like, Mr. Jones just wasn't acting right, and now Mr. Jones is really, really sick, versus we could have caught him maybe when he was septic, but not considered sepsis or septic shock.
Our facilities are top notch. I'm sure there's no issues with nursing homes.
I'm sure they're not.
They're fine. They're doing great. They're doing great.
I was a CNA in a nursing home before. It's not an easy job. All right, so the other thing, NICOM protocol. So this is basically a machine that we have. Again, I come from an ICU environment, so I'm used to swans and having things invasive to get stroke volumes and cardiac outputs. But this is a non-invasive machine we can use in the ED. Right now we're currently using it in the ICU until we can get a line dropped and things like that. But we can get stroke volumes off of it, and we can see the patient's fluid response. So if we give them fluids and bolus fluids, we can see how well they're tolerating it. So if I've got a CHF patient, renal patient, doc's worried we're going to fluid overload and put them in pulmonary edema, we can actually use that before I get the line drop for a CVP, or if they put a swan in or something like that. What else? Oh, sepsis order sets. So our division is trying to review our order sets, get them all somewhat standardized, so that I don't have Denton doing one thing, Louisville doing another, and Dallas, I about said UT Southwestern. Palliative care collaborative. So this is another thing. We do get these patients in, and you get them, you guys pick them up. Nobody knows what their status is, so of course you're going to bring them to us. And then, Susie calls up and says, well, my mom was a DNR. Okay, so what is the best thing for us to do? So trying to get a hospice involved earlier on, so that that patient, because they may not make it out of our facility, and especially if they don't want us to do anything now, what's the best thing for that patient? What's the best thing for that family? So trying to get hospice involved, where VITAS is in there a lot, and we have some other hospice facilities that come in, because we may not be able to get them stabilized enough to get them to inpatient hospice, but it doesn't mean that that patient shouldn't benefit from hospice. And then there's this Regional Healthcare Plan 9, and we are a participant of that. And so this is based on the Affordable Care Act. I learned the other day. So this is a lot of, Parkland, Las Colinas, ourselves, most of the major hospitals in the area are participating in these, and they have regions all over Texas. And so what this is waiver programs. If you do projects and you're showing that you're doing process improvement and things like that, apparently CMS has set aside all that money that they took away in the Affordable Care Act for DRG payments and stuff like that. And they set it aside and said, okay, you can still get that money if you show us these things. And so sepsis is one of the initiatives that we're working on for that. Blood utilization, and then point of care lactates in the EDs. We're working towards that, even doing them there, because our turnaround time is between 45 minutes and to an hour right now. Because you got to draw the lactate separate. It's got to be on ice. You send it down, and then the lab techs have to like reprogram the machine even before they do anything else on it. So it's kind of a cumbersome process. So where if we could do it on the ASTAT, it's like less than 10 minutes, and we have that. Okay, so what I do right now, and so you guys are the first group of actual first responders that I've talked to. But what I do right now is I send out these, they're called sepsis saves, and it's basically patients that we meet the time frames on in the ED from the time that they arrive to us through the transition to care. And so I send those out to the ED, ICU, whatever units are in that process. So this was a 64-year-old female, came in altered mental status, ETOH via EMS. Her lactate was done at 23:40. She got here at 22:45, and the blood cultures were drawn. We started the fluid. Her goal was 2250, and generally all these people get way over what the goal is anyway, but she got 4 liters. Antibiotics got started at 1254. Blood pressure was 107/55. She got sent to ICU with a diagnosis of sepsis. She actually got hypotensive at 055 and 555 and was started on Levophed, and then her blood pressure was back up to 100/47. So within that 6-hour time frame, she came in normotensive, she dropped to hypotensive, and we got her back to normotensive within the 6 hours, and that's one thing they're looking for too, because they don't want them to go over 6 hours without being back at that normotensive stage. And she survived. This was an 84-year-old female that came in altered mental status. She was febrile, she was tachycardic, and she came in via EMS. She actually screened, which is not common a lot of times unless they're really, really sick, screened positive on her sepsis screen from the initial onset. She got blood cultures drawn, IV fluids, she got 2 liters, antibiotics, lactate was drawn. She was intubated in the ED. Blood pressure was 66/44. She got started on Levo. We got her back up to 101/55. Her diagnosis was septic shock secondary to UTI and pneumonia. She also survived the discharge, but she discharged with hospice because she and her family both knew that she was subject to have this happen over and over because she aspirated from a prior stroke. And so they chose to go the hospice route with her so that she didn't have to kind of endure all of this again. And then this gentleman, who was an 85-year-old male, came in from via EMS. He was actually at a nursing home, altered mental status. His sepsis screen was negative, but his blood pressure was 58/38 when he got there, and he was hypothermic. So this guy had a perforated bowel.
Nice.
Yeah. He was 85. They did everything in the ED. We met all the requirements. His lactate, as you can see, is 11.8. So he was severely, he had, his bowel was not getting perfused, and that was causing that. Blood pressure, antibiotics, he got his fluids, and then upon transfer, 63/53, came to leave ICU on Levophed, and then his diagnosis was the septic shock and the perforated viscous. CVP was started. So his family, 85, perforated bowel. Do you want to go to surgery with an 85-year-old that already has a blood pressure of that? They opted again. They opted for hospice, no intervention from the OR, and he actually passed away before we could get him to anywhere. But that was again their choice, and sometimes it's better than what we could do. Questions?
Good job. Is there a sepsis patient that y'all transfer out?
Sepsis patient? No. No. We keep them all. We have 2 pulmonologists that are also our critical care docs. And our ICU was set up to take, anything. The only thing would be if our septic patient had a spontaneous hemorrhagic stroke, I'd have to send them out. But yeah, if there's anything with sepsis, that infection related thing, we've got IV docs, we got pulmonologists, critical care, all that. Thank you, guys.
Thank you.
Sorry.
Thank you.